today on the low tidal volume ventilation domain. I have no conflicts of interest to disclose. Really, the story begins back in the early 1960s when researchers showed that using small tidal volumes actually caused loss of lung volume in critically ill patients with hypoxemia due to right-left shunting through regions that were poorly ventilated. And this initially led in the early 1960s to approaches to mechanical ventilation that we'll call traditional approaches that prioritize use of higher tidal volumes. So tidal volumes in the range of 12 to 15 mils per kilo of body weight. And they were recommended at that time. As more physiologic studies were conducted, we had a greater understanding of lung physiology, and this led to the use of lung protective ventilation strategies with small tidal volumes that were meant to limit lung distension, limit ventilator-induced lung injury, as well as atelectasis trauma. And several studies actually supported this, and these studies demonstrated that mechanical ventilation strategies that permitted de-recruitment and recruitment of lung units or over-distension of lung units associated with high transpulmonary pressures could actually worsen existing lung injury and cause de novo lung injury as well. In addition, these studies showed that hypercapnia and respiratory acidosis were actually quite well tolerated if patients were well oxygenated. These studies also showed that effective pulmonary gas volume was reduced in ARDS patients. This is the concept of baby lung, and that ventilation, even with normal tidal volumes, could lead to more villi, more overdistension. There is a corollary, though, to this to think about, and that's in patients with severe ARDS, that we can have regional lung overdistension, and this can occur even if patients are ventilated with small tidal volumes. For this domain, we were clear up front regarding our terminology. And when we referred to low tidal volume ventilation, we thought of this as being in the range of 4 to 8 mils per kilo predicted body weight, and that the intention of prescribing low tidal volume ventilation strategies was not to optimize gas exchange and to accept certain levels of aberrant gas exchange, for example, PCO2 or pH, within safe parameters. On the other hand, we considered traditional approaches to ventilation as those that really did not prioritize limiting ventilator-induced lung injury, but rather focused on normalizing blood gases. So the PICO question that guided our inquiry was in adult patients with ARDS and COVID-19 related ARDS, does low tidal volume ventilation alone, compared with more traditional approaches to ventilation, decrease mortality? And you'll see here that we don't comment on plateau pressures or driving pressures in this PICO question. I want to upfront acknowledge my esteemed group of collaborators who are experts in this area on this slide. And I want to say that we included ultimately 7 trials in this domain. And in these trials, I want to acknowledge that ARDS was variably defined. 2 of the trials included patients based on lung injury score, as well as other parameters, such as having a risk factor for ARDS, having bilateral infiltrates on chest X-ray, and having in addition organ failure. Of the 7 trials, however, 5 included patients based on a range of P to F ratios. And you can see on the slide that these P to F ratios range from 150 to less than 300. In addition, the strategies that were considered lung protective in the intervention arms varied across these 7 included trials. And you can see the tidal volumes ranged from anywhere from 4 up to 10 mils. And the adjustment was either based on predicted body weight or actual body weight or ideal body weight. So they were not standardized in their approaches across trials. Similarly, there were only 3 of these 7 trials that included a limitation of plateau pressure below 30. Important points to note in these 7 trials. Of the 7 trials, 5 were stopped early, some for benefit, some for futility. And no trial specifically evaluated COVID-19 patients with ARDS. Pardon me. Our approach to pooling data was really, in the primary analysis, we decided to only include trials that were of moderate to high quality based on grade methodology. And in a secondary analysis, we would include all of the lung protective ventilation trials. So what were the results? Well, the primary analysis included 3 trials and found no evidence of a mortality benefit favoring lung protective versus traditional approaches to mechanical ventilation in patients with ARDS. And heterogeneity was significant here with an I-squared value of 61%. But the secondary analysis, even though it was consistent with the primary analysis, approached statistical significance with a risk ratio of 0.82 and a p-value of close to 0.07. Again, there was the analysis of heterogeneity was inconclusive due to imprecision with an I-squared that would be considered moderate in the range of 47%. With regard to secondary outcomes, we did not find statistically significant differences of the effect of the alternative approaches to mechanical ventilation strategies in patients with ARDS on ventilator-free days or on barotrauma. So considerations in developing recommendation statements, there are several considerations. I'm going to highlight them here. First of all, we considered the balance between patients' values and preferences. And as Carolyn nicely alluded to, we had several patient and family advisors that were engaged throughout the guideline process and in developing recommendations. We also considered the balance between desirable and undesirable effects of the alternative approaches to mechanical ventilation. We considered resource use. We considered acceptability to all involved stakeholders at the bedside. We considered feasibility. We considered equity. And importantly, we considered the extremely strong rationale that exists for using low tidal volume ventilation from both animal as well as human studies. So with this in mind, we downgraded the evidence for one trial that was not published in full. So this would be in the secondary analysis. And we downgraded the evidence for 2 trials, one that kept PEEP in the intervention arm 2 centimeters above the lower inflection point of the PV curve, or at 13 centimeters of water, and another that kept PEEP 2 centimeters above the lower inflection point and also permitted use of recruitment maneuvers as an ancillary lung protective ventilation strategy. We considered that the tidal volumes were variably calculated, some using adjusted body weight, some using ideal body weight, some using predicted body weight. We considered that the trials actually achieved different tidal volume gradients between the intervention and the control arm. We also acknowledged that the low tidal volume ventilation strategies likely required increased sedation and/or paralysis, and that these effects, along with those related to permissive hypercapnia, were not exclusively evaluated in this review. In addition, we noted that no new trials have been published in this area since 2006. Considerations in developing the recommendation statement related to COVID-19 trials. Whereas I said before, there were no trials were actually conducted during the pandemic on COVID-19 related ARDS. However, we reasoned that there was really no rationale for saying that the underlying physiologic support related to using low tidal volume should be different in COVID-19 versus non-COVID-19 patients, that there was a similar biologic plausibility, and the physiologic mechanisms that lead to lung injury were similar or the same. We acknowledged, however, the rate of serious and prolonged multidimensional disability may be exacerbated by prolonged deep sedation and paralysis in patients with COVID-19 ARDS. And consequently, we had to downgrade the evidence for indirectness in this recommendation statement. We did not evaluate explicitly the effects of airway pressure and driving pressure as alternative lung protection ventilation strategies in this PICO question. So our final recommendation statement reads as follows. We recommend, not we suggest, we recommend the use of low tidal volume ventilation strategies, 4 to 8 mils per kilo predicted body weight, compared to larger tidal volumes, and we put in brackets, those are the traditionally used strategies that strive to normalize blood gases. And this is to reduce mortality in patients with ARDS not due to COVID-19. This was a strong recommendation, even though it didn't achieve statistical significance. And this was also based on expert opinion, based on the strong rationale that exists in animal as well as human studies. And this was assigned a high level of evidence. With regard to COVID-19 related ARDS, as I mentioned previously, we downgraded this recommendation due to indirectness, and therefore we still recommend the use of low tidal volume ventilation strategies, the same 4 to 8 mLs per kilo predicted body weight compared to large tidal volumes to decrease mortality, but now this has moderate level of evidence. And you can see in this final slide that our tidal volume recommendations align with the previous 2017 guideline recommendations. They're completely in agreement as indicated by the 2 green boxes, and really there is no change in recommendation. I can also add that our guideline recommendations also align with other guideline recommendations with regard to the use of low tidal volume. So in my final slide, I would just like to thank the ESICM for their sponsorship of this guideline. I'd like to thank Guy Francois, who was incredibly helpful during the organization of this particular domain, Danielle Poole for his statistical advice and methodology guidance throughout development of the guideline, and most importantly, Carolyn Calfee, Luigi Camparota, and Giacomo Grasselli for their leadership as co-chairs in developing this guideline. Thank you very much.
Thank you very much, Karen, for explaining so well not only the decisions and the final recommendation, but more importantly, the several dimensions that went into that decision making. So thank you for that. Could I ask whether there is any questions or any comment on the guidance or on the presentation? Any addition? If not, in the meantime, maybe Karen. One of the things, obviously, we've looked at in the domain the evidence around tidal volume as you defined, and then in the final sort of diagram there was mention about driving pressure, plateau pressure, more as a guidance and safety. So, on a practical way, where would you see your sort of hierarchy, among these 3 things? So tidal volume as a setting, plateau pressure as a threshold, or as a safety threshold, and where does driving pressure fit into it? Because we mentioned right at the end of the guidelines. So I would love to hear your opinion about that.
Yeah, it's a great question, because obviously this is all part of a lung protective approach to ventilation. And it's interesting because, these studies stopped after 2006, and there was a lot of controversy at that time in terms of what was low tidal volume and what was traditional approaches to tidal volume. But I think there's also, as you're intimating by your question, there's other lung protective approaches to mechanical ventilation. So the concept of plateau pressure, we use the threshold of less than 30 in our conclusion, in our discussion. We didn't mention a specific driving pressure of 14 or a specific value, but clearly these are all lung protective approaches to ventilation. There are other approaches that we could think about, elastins kind of normalized to predictive body weight, etc. There's other approaches that also could be evaluated, and some of them are all interconnected. And looking at the body of evidence, you can generate many questions about where to go in the future. For example, if a patient's plateau pressure is already 30, should we continue to reduce their tidal volumes? Or is too much of a good thing actually ultimately a bad thing if we continue to reduce tidal volumes? So there's many, studies that we can think about that would further our knowledge in this area and help to, better define what's lung protective in the general population. And then, of course, you can go to personalized approaches to mechanical ventilation and say, the one-size-fits-all may not include everyone, and we may need to adapt certain approaches to specific patients with personalized approaches to mechanical ventilation.
Thank you so much for the comprehensive and wise suggestions. We've got a question over there.
Thank you very much. My name is Shamsuddin from the UK. Speaking of the different approaches, I wonder if you have any impression about the APRV used in ARDS as a completely different approach. You mentioned the side effect of restricted tidal volume, small tidal volume, the need of sedation, the need of paralysis, and then the other side, APRV, doesn't have that. So, APRV.
Yes. We actually did a very broad literature search, and we probably identified in the neighborhood of about 35 trials that we could consider broadly lung protective, and there were several that looked at APRV. We did not ultimately end up pooling those trials in this particular review. However, other systematic reviews and meta-analyses have tried to look at that to say, is APRV an alternative lung protective approach that could be used? Personally, I don't know. I think the jury is still out on that one myself. But, in the absence of a really large, well-designed, trial, I think it remains one of the strategies in our armamentarium.
Thank you, Karen. Well, given that you come from the UK, we'll be starting a big trial in January 2024. I'd love to have you as a site participant, so thank you so much.
Yes, I have a question, just to continue the question of Luigi for the clinical practice. Years and years ago, after the RDS-NET trial, comparing 6 ml per kilogram and 12, many people use 6. They are strict. They strictly use 6. So you said, finally, low tidal volume ventilation could be between 4 and 8 ml per kilogram. So it's not criminal if you use 8, and if driving pressure, plateau pressure, whatever you want, is acceptable to stay with 8 ml per kilogram.
I mean, yeah, I guess we don't know the answer to that.
No.
It is a range, right? And we don't know the answer to that. Should you feel obliged if your plateau pressure and your driving pressure are safe, or you consider safe, should we feel obliged to reduce tidal volume further or to a lower level? Or is there some type of, curve where you lose the benefit and you gain negative?
You have no the answer to these questions.
Yeah, we don't know the answer to this, but I think it's a great area for future inquiry.
Question?
Sometimes when we put surrogate direct parameter, driving pressure, plateau pressure, we forget that this is not the aim for the ventilation. The aim is the perfusion at the end. So it's the content of the oxygen, time the cardiac output, and then we see all the rest. So when we talk about only tidal volume, we forget that also that we have the minute ventilation. We have a lot of that space, and then we forget what to tell and guide our clinical judgment about minute ventilation. So all together I think must be looked in different way, in different, only putting some parameters.
I agree. That's well said. And I agree. There's always this trade-off with tidal volume and respiratory rate, and it's a dynamic process, and I completely agree with what you're saying.